I guess we can start.
All right. Good morning, everyone. We're very pleased to have you here on our webinar this morning about global disparities in congenital heart care. I am very honored to have three rather amazing speakers this morning with us, and then three additional very esteemed panelists. I will briefly introduce you to the speakers. First up is Dr. Jeffrey Jacobs. He's a professor of surgery and pediatrics at the University of Florida. So Dr. Jacobs, if you can share your screen, let's get started.
Excellent. Well, first of all, good morning, everybody. It's an honor to have the opportunity to speak on a webinar with all of my colleagues for and with Global Arch. What I am going to do this morning is give a brief 5-minute introduction to the World Congress of Pediatric Cardiology and Cardiac Surgery. And that's important for this particular webinar because many of the initiatives that will later be discussed on the webinar will be operationalized and will be active at the upcoming World Congress. So I'm going to share my screen, and I hope everybody can see my screen now. What I've done, rather than use slides, is I've taken everybody directly to the website for the World Congress of Pediatric Cardiology and Cardiac Surgery. And on this website is a variety of information that is available that explains the size and scope of World Congress. There's a few things I wanted to point out, and I was going to show a short video as well. World Congress is held every 4 years. This is the 8th World Congress that has taken place. That's a joint World Congress of Cardiology and Cardiac Surgery. It's normally held every 4 years, but our World Congress is 6 years since the previous one that was held in Europe in Barcelona because we had to delay 2 years because of COVID. The World Congress is going to be held in the end of August and beginning of September 2023 in Washington, D.C. The meeting as of yesterday had over 3,000 registered attendees. There's an abstract program that has over 1,800 abstracts that have been submitted for scientific presentation. There's a few things I'm going to show from the website that will exemplify the size and scope of World Congress. The World Congress is hosted by the United States this time. The countries that host it rotate. The last World Congress was hosted by Turkey, the World Congress before that by South Africa, before that it was in Cairns, Australia, and before that in Buenos Aires, Argentina. Each of the dots on this map of the United States represent a children's hospital in the United States who has supported the World Congress, partnered with us, and is providing financial support. In addition to that, we can look at a number of organizations that have canceled their meetings for the year 2023 and instead embedded their meetings within World Congress. This includes the World Society of Pediatric and Congenital Heart Surgery, Cardiac Neurodevelopmental Outcomes Collaborative, dozens of other organizations, including those shown on this slide. And importantly for this webinar, Global Arch is having their 2023-2024 meeting at the World Congress of Pediatric Cardiology and Cardiac Surgery. One can go to this website and learn anything they need to learn about World Congress, from a summary of the previous World Congresses and the history of World Congress to detailed information about the scientific program stratified by the different days. There's links on this website to go to registration. Importantly, there's also links on the website that one can go to get help obtaining a visa. So there's a special visa information link that's right here. And from here, one can request an invitation letter and get help with their visa. And I know that Global Arch has been very helpful with the visa part. The last thing that I will do this morning is I'm going to show a very brief 3-minute video. Normally, if one goes to the website, one hears sounds with this video, but on Zoom, there's going to be no sound. So I'm going to explain the different parts of this video. It's 3 minutes long, and it really summarizes the entire program of World Congress. Imagine exciting music behind this instead of my voice while you're watching it, but here we go. So that's our logo. Again, this is set to some good music. That's our tagline: care for children having adults with congenital heart disease. This meeting too. This is going to go through the details of the scientific track. These are the 22 subspecialty tracks, which include cardiology, cardiac surgery, anesthesia, perfusion, critical care, nursing, administration, and importantly for this webinar, advocacy, quality improvement. All of these tracks, they're individual scientific programs, but also have unique collaborative sessions where tracks are overlapping and mixed together to create collaborative opportunities between the different subjects. This is the map I showed you before, listing all institutional partners in the United States who have each provided a minimum of $5 US support. These are the different societies endorsed World Congress support the exhibit hall, and these are the organizations that have canceled their meetings and embedded the meetings in the world. This is a picture of our exhibit hall. There's going to be a lot going on in our exhibit hall, including a unique global health advocacy village that I'll talk about a little bit over. This global health and advocacy village is for charitable organizations to interact with each other. There's a multi-dimensional anatomy lab with 2D, 3D, and 4D imaging. We're now up to close to 2,000 abstracts, most of which were presented as posters, but there will be 10 oral presentations within each track. Washington, D.C. is a great city that we've got hotel rooms for 5,000 people, and all of the activities that one can do are free to do. All the tourist attractions are free. So that's a quick, very short video summarizing the World Congress. The last thing I want to do before I turn it over to everybody else is briefly mention the concept of Global Health and Advocacy Village. The exhibit hall is huge. It's the size of 3 United States American football fields, which I guess is about 2.8 soccer fields. And in this exhibit hall, there will be a section of the exhibit hall specifically for global health and advocacy. And we anticipate over 100 organizations dedicated to charitable heart surgery, global health, and advocacy, all having a presence within this exhibit hall as a platform to collaborate and interact and work towards some of the initiatives that will be discussed by my colleagues on this Zoom call. For me and for Gil as the co-directors of World Congress, these initiatives are the most important part of World Congress. This Global Health and Advocacy Village is the most important part of World Congress. And I'm very grateful to everybody on this Zoom who has taken leadership roles in creating these opportunities. With that, that's my brief introduction to World Congress, and I will turn it over to my colleagues who will talk a lot about the global health and advocacy initiatives that will take place at World Congress. And I'd like to thank Amy and Bistra for their leadership at World Congress and for the opportunity to speak.
Thank you so much, Dr. Jacobs. And you gave us a wonderful overview despite the lack of exciting music. The next person I would like to introduce is Dr. Kathy Jenkins, who is a Senior Associate of Cardiology at Boston Children's Hospital. And if you could share your screen, Dr. Jenkins, and Dr. Jacobs, I don't know if you need to end your sharing. There we go.
Okay, is that working?
Yes, thank you so much.
Wonderful. Well, first of all, it's hard to describe how exciting it is for our community to get together at the World Congress meetings, and the momentum is building, and so is the excitement. But for me, when I go to the World Congress, one of the most important things I am just continually reminded about is how big the world is and how many people are practicing pediatric cardiology around the world. You can't help but just be immediately reminded of the global inequities in our field in our lifetime. And I'm here to just talk a little bit about the data around that and the message around that as part of what we're all here to do, which is think about solutions and work together towards them. So what I want to do, first of all, is to just start with the takeaway message. And so the most important thing, just to say, is that 9 out of 10 people with congenital heart defects do not have access to life-saving treatment for their condition. And so death and disability from CHD is much greater in low and middle income countries than it is in high income countries. For some reason, my screen is not advancing. I'm not sure why. There we are. Okay. Sorry about that. So there's beautiful analysis that's been done in our field, leveraging the global burden of disease work that's been funded by the Gates Foundation. It was done by some researchers, led by some researchers, I should say, at Children's National a few years ago. And it's really given us a lot of information that we didn't have before about the global burden of congenital heart disease. And it really leads us very directly to understand why there's such huge inequities in access to care. The first one is really very simple. It's where people and babies are born in the world. And most of them are born in low resource settings. That's just the fact of it. The fertility rate is higher in these areas of the world. And there's other components of why people get congenital heart disease associated with poverty and the like. And you put all that together, and most of the babies and children born in the world with congenital heart anomalies or other birth defects are born in low resource settings. And at the same time, this study that was done looking at the workforce issues a few years ago by Zilla and others that was published in Global Heart really showed how striking the differences in the number of caregivers in these regions. And this is just a map of areas that they looked at following on some work that had been done previously. But it basically shows that there's almost 100-fold difference in the number of people who are trained to take care of people with congenital heart disease in low resource regions of the world compared to regions where I practice in Boston. And then this is a picture that I took off the Global Burden Disease website just last week. That when you put it all together, where people are born and the lack of access to care, by far and away, the death and disability from congenital heart disease across the lifespan is much, much greater in lower resource settings around the world. And this picture here showing the DALY rates, the age standardized disability adjusted life year rates, around the world, all of the areas in yellow and red are much greater than the areas in blue. And it's just really easy to just look at this visual and understand how serious this problem is when you put it all together. And I will say these graphs were actually generated using data from over 5,000 sources. And there was a small little fine print part of this one that showed that the vast majority of people with congenital heart disease actually, they don't just live with disability, they actually die from their disease. So that's key takeaway one. Key takeaway number two is that even though care is getting better, inequities in care are getting worse. And this is actually a study that was done. It was a beautiful paper, actually, trying to tease out, are things getting better or are things getting worse in our field? It was done by Sue et al. Just a few years ago. And it was essentially a more in-depth analysis of some of the global burden of disease work. And just to say over here, the way they were looking at it was the percent of non-communicable diseases that came from congenital heart disease. In our little bar here is this one, this like darkish red bar is congenital heart disease. And you can just see here the number of deaths from all the non-communicable diseases, but in particular congenital heart disease across the different social demographic indexes where there was much lower in the high side than in the low side. And then in these blue bars here, they actually looked over almost a 30-year time span from 1990 to 2019, whether or not things were improving. And there was a slight improvement globally, but there was a dramatic improvement in high resource settings and almost no improvement at all in the lower resource settings. And they showed the same data over here a little bit different way in this analysis they did called a period effect analysis, where basically you start in 1990 up here in this corner, and then it's how things have improved over time. And globally, things have definitely improved. In high resource settings, things have improved dramatically. But in the lower resource settings, there was really a flattening, maybe a little bit better lately. But what this means is that although care is getting better in many places and a little bit better even in low resource settings, inequities in access to care are actually getting worse. And so just in 2017, over 250,000 people died in the world with congenital heart disease, and only 3% of those were in the highest quintile. This data here was in quintiles of essentially access and opportunity. And all the trends that we have say that if we don't do something dramatically, these disparities will continue to worsen. So key takeaway number 3, I really wanted to say something about this and speak to it. Why? Why is it that we have these dramatic inequities in care for congenital heart disease? And let's just say that the reasons behind that are complex. And in order to just talk about that really complex issue, I figured, since I just came back from an artificial intelligence in medicine last week, I would just ask ChatGPT. This is a really hard question. I don't know the answer to it, so let me just ask. And I'll just read for you what I learned from ChatGPT. My question was, why are some regions of the world more impoverished than others? And here's what the answer was. And there is no simple answer to why some regions of the world are more impoverished than others, as poverty is a complex and multifaceted issue with many underlying causes. Some possible reasons include historical factors. Many impoverished regions of the world have a history of colonization and exploitation, which has left them with fewer resources and less economic power. Additionally, areas affected by political instability, conflict, or war may have experienced significant damage to their infrastructure, services, and economy. Limited access to education. Access to education is essential for economic development, but in many regions of the world, poverty and lack of access to education go hand in hand. Inadequate education and limited opportunities can perpetuate a cycle of poverty that is difficult to break. Environmental factors. Certain regions of the world are particularly susceptible to natural disasters or environmental degradation, which can damage infrastructure, destroy crops, and exacerbate poverty. Political and economic factors, corruption, poor governance, and economic policies that prioritize the interests of the wealthy can create economic inequality and hinder poverty reduction efforts. And last, discrimination and inequality. Discrimination based on factors such as race, gender, religion, or social class can limit access to education, healthcare, and employment opportunities, worsening poverty. Additionally, social and economic inequality can create systemic barriers that prevent marginalized groups from accessing basic resources. So I just not going to say any more about that. I think the message speaks to itself, that for a variety of reasons, things are unequal in our world, and that's resulted in unequal access of care for congenital heart disease. And I just brought this slide up from a recent New England Journal of Medicine publication about rheumatic heart disease. And just to say that for care for rheumatic heart disease, the problem is even worse. And that's because even getting rheumatic heart disease in the first place is way more likely if you live in low resource settings because of issues with crowding and just honestly getting strep throat in the first place. So key takeaway number 4, though, starts to just really turn our attention to actions. At this point in time, the blueprints to reduce global inequity for congenital heart disease care are available, but they will require a dedicated effort in each country. And just to start, I'd like to just give a shout out to the organizers for this meeting, 2 organizations that I'm personally connected to and very proud to be, have really done a tremendous amount of work already in this field. I'll just point out here the case for the Invisible Child, the Invisible Child series that was put out by Children's HeartLink a couple of years ago in 4 editions. It really lays out the issues and it lays out a pathway for solutions, and it's available on their website. And the second one was one of the first actions that Global Arch did, which is really pretty amazing, which is to just put it out there as a declaration of rights of individuals affected by child onset heart disease, basically just declaring that people have rights to the health care that they need, regardless of where they're from. Some of the newer things that have also come out recently, I didn't put a slide of this, but there's just about to be a paper coming out from a public health perspective. It's in press now, really lining out in a lot of detail about what exactly would be needed to create the programs around the world and to get going on that. There's also been a lot of work by a young surgeon-to-be, Dominique Vervoet, and others, really trying to get congenital heart disease into the national planning for different countries. But as I said, it's going to have to be something that's effectualized at the local level. This is a recent publication by one of my colleagues and friends, Nestor Sandoval and his group in Colombia, that was recently published, doing a very in-depth look at their country, Colombia and South America, and really mapping out where there is care being delivered, where there isn't. All the gray areas have no care in this place. And also even how the outcomes were, how people were doing. And it's this very grassroots level at each country, mapping things out in this detail and then trying to solve it. That's going to really be what we need to do to improve access. So key takeaway number 5 is really, though, that success in creating sustainable CHD programs in low resource settings is achievable. And I say that because really success is already happening. One of the first things that we'll probably hear about more from others on the call is the World Health Agenda. The World Health Agenda really is very important, and they put forward healthcare priorities. The most recent version are called the SDGs, Sustainable Development Goals. And there's several of these goals, perhaps most importantly, the under 5 mortality rate, that are very pertinent to reducing death and disability from congenital heart disease. And that Invisible Child series that I mentioned earlier really called out and highlighted just how important these sustainable development goals, and particularly the goal around under 5 mortality, are towards dealing with the issue of getting governments and others around the world to focus on congenital heart disease. And in this just very elegant slide, they show that as the under 5 mortality rate from all causes drops, all of a sudden, the proportion of that mortality that's from congenital heart disease really emerges in a way that the healthcare and public health professionals can't really ignore. And so it turns their attention to this problem. And this is a map, again, from just last week, showing the improvements in the under 5 mortality around the world. And again, Africa in particular, and some areas in Asia and other places, have been left out a little bit in this improvement or are behind. But in many parts of the world, this under 5 mortality goal is getting closer or is even achieved. And that's going to highlight as a next step, really tackling the problem of congenital heart disease care. And then I'll just end with just a little bit of data from our own project, the IQIC, the International Quality Improvement Collaborative for Congenital Heart Disease. This is just a map of where the centers are that are participating in our project in 2022. And they're all in low and middle income countries. I'm not going to show a lot of data, but this is a very important slide just showing that survival after congenital heart disease. This is a standardized, very complex model of improvements over time. But over a very recent period, this is only a 10-year period, there's been dramatic improvements in survival when in low resource settings for congenital heart surgery in particular. And this is just a new analysis that we've just done. It was done by a Harvard medical student. She just won a Best Global Health Award for this work. And she's aspiring to be a congenital heart surgeon and just getting started with training. But she actually looked at the simplest so-called lesion, so to speak. I'm sure people who have it don't think it's simple, but atrial septal defects, and really showed that just over this 10-year period, very short period of time, there's been a dramatic improvement in the IQIC sites for their survival for ASD, so much so that it is right now equivalent to the outcomes from the United States. And so just to end my key takeaways, just so everyone remembers, 9 out of 10 people do not have access to life-saving treatment for congenital heart disease. So death and disability is much greater in low and middle income countries than in high income countries. Even though care is getting better, inequities in care are getting worse. The reasons that dramatic inequity in care exists are complex. The blueprints to reduce global inequity in care are available, but will require a dedicated effort in each country, and success in creating sustainable CHD programs in low resource settings is achievable. And with that, I will stop and hopefully stop sharing and move along with the panel.
Thank you so much, Dr. Jenkins, for such an excellent framework and sort of setting the stage for us for the call to action. And now we're going to hear from Bistra Zheleva, who is the Vice President of Global Strategies and Advocacy at the Children's HeartLink. Bistra, if you can go ahead and share, thank you. And I also wanted to remind people that if you have a question, we're not going to be able to see you raise your hand. So please type your question in the question and answer box.
Thank you. Can you hear me well?
Yes, thank you.
So I'm not going to take a long time. I think Dr. Jenkins gave a great overview of what we're seeing today in terms of inequities in pediatric cardiac care. What I would like to share with everyone who's attending today is that a group of us have drafted and are distributing around a call to action to address the global burden of pediatric and congenital heart diseases in conjunction with the World Congress. And I think the culmination will be at the World Congress, and really to try to address those inequities that we just heard about from Dr. Jenkins. So what is the call to action? It's a document, it's an advocacy document that we hope to be using in the future and in meetings with governments, in meetings with multilateral organizations like the World Health Organization or UNICEF or World Bank. These are all organizations that influence healthcare policies around the world, especially in low and middle income countries. We hope that every One of you who signs it, or every patient and family organization that signs it from a different country, they can take this document and bring it to their government and ask for action. This was based on the Invisible Child that Dr. Jenkins earlier shared with us a little bit about, but it has 4 levels of asks. One is to increase capacity for people with pediatric and congenital heart diseases. And this really is where our ask here is about domestic and global investments, to bring investments from the private sector, development of hospitals, and really developing more infrastructure in the future. Building the pediatric and the congenital heart cardiac workforce of the future. This is a true determinant of the inequities that we see. We do not have enough trained pediatric cardiac specialists and congenital heart specialists that can take care of people, given the numbers that Dr. Jenkins showed us. We need to be thinking about not only today we cannot address the needs, we cannot address the needs tomorrow. And so this is something that every country almost have to be deciding for themselves, but this is a big gap in our in the world today. The next one is closing the data gap, and data means that if we have data, policymakers will be able to make the right decisions and to be using data to make decisions. We, as you saw earlier, 9 out of 10 people don't have access to quality care. This is a big number, and this is something that we need to be, again, addressing, and every country needs to be addressing. And this can happen only by doing studies in each country, and in each country, understanding what exactly the burden is. What are the costs of pediatric cardiac care and congenital care? What is the what are research topics that are specific to every region and every country? Without data, policy decisions are not being made, and without data, a lot of these people stay invisible. And last is about financing, which is, I'm sure everyone who has had to deal with this has been touched by this actually very unfortunate inequity. Many families have to go into poverty in order to finance the care, to pay out of pocket for the care of their children. It's an expensive personal expense, and that is why it needs a national policy that helps families not go into poverty. So this is definitely something that needs to be addressed pretty much everywhere in the world. If anyone, this is unaffordable for most people in the world today, including countries that are high-income countries. So it's a big topic that needs to be mentioned. So how do we sign on to it? There is an online form that can be signed by both individuals and organizations. And again, we welcome everyone to go on. There's this call to action is published on the website of the of Global Arch, as well as Children's HeartLink, as well as it will be very soon up on the World Congress website. And you can find this form, click on the link and find this form, and it walks you through few steps. It really takes half a minute to sign, to share your name, where you work, your contact information, and whether you're signing on behalf of only yourself or behalf of your organization. So again, we want to welcome everyone to sign the call to action. The more signatures we collect, the more strength we give to these asks that I shared with you. And I hope that we can be able to see some of you at the World Congress, and again, share this with you in the future, and you can use it in your own advocacy efforts. And I'll stop here.
Thank you so much, Bistra, for a wonderful overview of the call to action. And now it's my honor to present the panelists that we have invited to comment on the call to action. And the way we are thinking about this is, as Bistra emphasized, we know that this is a global problem, but we also know that the solutions have to be done locally. So I want to begin with Mr. Farhan Ahmad. He is the founder of the Pakistan Children's Heart Foundation. Behind him, you can see a picture of the hospital that he is currently building. And I also just want to say that his organization was one of the founding members of the Global Alliance for Rheumatic and Congenital Hearts, or Global Arch, and he also was a founding board member. So, Mr. Ahmad, if you could comment, I would love to hear your comments essentially from two perspectives. Obviously, from your perspective of a person who is in Pakistan and a leader, but I know you have a kind of unique perspective in terms of who's speaking, in terms of your personal connections. So what are your comments about this?
All right, thank you very much. And it is an honor to be here in such a strategic and important group of people who understand what congenital heart disease especially needs to be done in the low-income countries. Amy, our experience from the day one has been that the thing that you guys have summarized, there needs to be a coordinated effort, especially on the 4 areas. When we started the foundation in 2010, our initial goal was to immediately start financing the heart surgeries. But that's just one aspect of what
Farhan, my apologies, but we're not getting your video. I mean, your audio. So perhaps you can start again. He looks like he lost his signal. And I will note that Pakistan is currently having major problems with their infrastructure, and particularly internet, because of a lot of reasons, including the political issues that are going on there. So what I think I will do is, as we are working to get him back with us, there he is. Great. Let's see if this works this time. Farhan, can you hear me? And go ahead and continue your comments if you're able. I think I'm going to move on. Just as he's getting started with this, I want to go to Dr. Sreehari Nair, who is in the Indian Department of Health and Family Welfare in Kerala, India. And Dr. Sreehari, as the only person actually working in government and in a health department, I would love to invite your comments both about the call to action and the situation in Kerala, which I think is in some ways really a success story in many ways. So if you could give us some comments from that point of view, that would be great.
Thank you, Amy. This is actually a wonderful opportunity for me. And it's a privilege to be part of this. So about the call to action, yeah, this is where we also started, and may have just started rolled out things, and a lot of way to go now, even now. The deficiency with regard to the capacity or infrastructure is a challenge when we consider India as a whole. But we are really fortunate to be here in Kerala. We had somehow had good capacity, especially on the infrastructure side. And major challenge that we had at that point was on financing, how to get the finances. And there also there was some good good things happened from the federal government. They had a program. They initiated a program called RBSK, that is a Rashtriya Baal Swasthya Karyakram, which decided to look at the quality of life of children beyond the survival. There is a motto of that program. So there we got an opportunity to tap some resources, especially on the finance side, to fund the surgeries. So that is one point that everybody will start looking at. How can you have more surgeries or more children saved through surgeries or interventions? We're fortunate to have the partnership with Children's HeartLink, we thought we will not be just doing some surgeries, but to have some system built for future. So this is in the same line as that what we have seen in the call to action. We looked at the infrastructure. What are the gaps in the infrastructure? What is our capacity to diagnose? What are our capacities to stabilize children once we identify it? How will we confirm the diagnosis? What are our capacities, especially in the segment of pediatricians who once see a case? How can they take that case to the next level where the service of a pediatric cardiologist is available? So we try to establish a linkage between the point where the cases are identified or the cases land up and where we have the opportunity to manage the cases. So when we looked at the capacity in the whole state, we have around 6-7 points, the surgical points or the institutions where we can operate. And we have around maybe 200-300 public or maybe the institutions where newborns are born and were identified or suspected to have congenital heart disease. So we established a linkage, we use the technology, we developed a web portal where those children can be registered and the cases can be seen by those experts. And the willingness of experts was one point. All these people came together and supported the government. The government, of course, the government needs to take some key steps and key roles that we had that opportunity and we had that privilege to be part of that. So when the policies are made, of course, we need to see what is happening and what are the deficiencies. Somebody should come to us and tell us what are the problems are. And that happened, and there were people in government who could understand things, and this somehow came as a priority, which usually we don't expect in an LMIC setting, and that I couldn't see in many other states in my country when we started advocating for similar program or the replicating such programs in other parts, because the priorities are different. Or maybe it was our failure to convince people that this is a problem. That is a point that Mr. was telling a little bit earlier. So we need to tell people that this is a problem and action needs to be taken today, because we are losing some children. We are losing the newborn this year, and they could not be saved next year if we are not having such a program. So maybe it is our failure. Maybe the data is not there. That's why data gap is a significant thing. We will have to move ahead, and to my understanding and my experience, none of these things are not a problem. Finance is not a problem. Finance will come. The data, of course, you can gather a lot of information. There are a lot of settings where you can collect data, but people should come together. There should be like-minded people, as you people sitting together, or we all together. And if we can start working, we can have similar programs. And we need to think. We started looking at different aspects. Once we had the problem, the program started. We looked at different aspects: the quality of the programs, the quality of life of these children, the neurological outcome. Different aspects are being looked, and that has contributed a lot in other aspects of healthcare as well, especially in the pediatric critical care, and maybe more sort of congenital other anomalies are being identified. So this is going to definitely improve the whole set of health system, and this is going to benefit a lot more children, even beyond the limits of congenital heart disease or maybe rheumatic heart disease.
Thank you so much, Dr. Sreehari, for an excellent discussion or overview of both your successes and what continues to be a challenge there in Kerala and in India in general. I'm going to circle back to Mr. Ahmad, who I believe has been able to rejoin us. There he goes. So I know you had begun talking about the situation in Pakistan and Pakistan Children's Heart Foundation. So please continue.
Thank you very much, and apologies for this connection. These kind of challenges we keep on facing on a daily basis in low-income country. Actually, Amy, what I was trying to explain that when we started, we had a vision that we need to support the financial heart surgeries of the children who are waiting for their heart surgeries. But there was not just something that we can count forever. There has to be a need for a coordinated effort, and as very rightly mentioned, all the 4 points. And I'll quickly give you my input that the infrastructure has to be built. Without the infrastructure, you cannot bring medical mission from outside the country. People who really want to contribute, they cannot. Second, like we have focused that we need to build Pakistan's first dedicated children heart hospital, but that's not alone can do a lot. Because looking at the quantum of the disease, we have to work with other partner hospitals. So the second thing we did was working with the pediatric cardiologist and cardiac surgeon who used to work for the government setups. But what we did, unfortunately, the kind of compensation they get from the public sector is not enough. So they probably were of the view that they have to move outside Pakistan. So we developed an ecosystem where we collaborated with different hospitals, private hospitals. So we developed different pediatric cardiac surgeries setups in those hospitals, which ultimately helped us complete about 3,500 procedures in the last 10 years. And that has been something which I will encourage all the low-income countries, because look, we deal with two sensitive things. One is the heart and the second is the child. And in my last 10 years of journey, I have never seen any individual who I have actually presented the project and they have not opened their heart and their pockets for this. Lastly, I think another thing that we have been able to achieve, convince the public sector, the government, that you guys need to add the congenital heart procedure in the universal health coverage. So earlier, the universal health coverage, which was one of the great initiatives of the last government, there was no congenital heart treatment available. But as soon as we, along with the other stakeholders, did a lot of effort and finally it became part of that, immediately there was probably 100% increase in number of cases that were sponsored. So it has a joint effort, because people who cannot afford and people who can perform the procedure, there was a gap. So when the government started to fund that gap, so now, luckily, instead of 8, we have about 16 pediatric cardiac surgeons across Pakistan. Initially, when we started, there were only 30 cardiologists. Now we have about 60 plus pediatric cardiologists in the whole country. Still, it is very less, but I think as a call of action, I would 100% support that these 4 areas, if we focus coordinated, I think it can bring a real change.
Thank you so much. And that was your work in Pakistan is truly inspiring. I just to end, and I know we're short on time, but did you want to offer any comment about what your inspiration was for starting this work?
Oh, yes. So my little daughter, Aisha, she was born with the severe congenital heart disease. She was born with the right ventricle not fully developed. We had to struggle a lot. I own a technology company. We didn't have any problem financially, but we were not able to save her. It was very difficult time for the family. So she lost us in 2000 and we lost her in 2012. So during that time, we realized that something meaningful needs to be done. So we formed this Pakistan Children's Heart Foundation, and I'm very, very thankful to Amy, yourself, Bistra, and everybody else in the panel, that you guys have been an amazing, exceptional support. Because what we believe that setting up vision is critically important. So that's why we have not named this institution on my daughter's name, and we believe that it's a problem which needs to be taken care when we are not there. So what we have done, we have written a vision for our institution. The next 50 years, where do we want to see this institution growing? And the only thing that I think I can summarize is, for anything you need to have a passion and some sort of a spark which keeps active every day. So and that's what is happening.
Thank you so much. I want to now turn to Dr. Mattos, who is the director of the Maternal-Fetal Cardiac Center at Real Hospital Portugues in Brazil. So, Dr. Mattos, if you can share your screen.
Thank you very much. I think I'm there already, correct? I'm just calling, similar to Dr. Farhan Ahmad. I am in the middle of a construction in the hospital, and there's some noise. I just asked them if they could stop for a minute at least. But thank you very much. It's an absolutely great opportunity to speak to this international panel of great experts and people who are doing incredible things around the world. So I'm very, very happy to have been invited, to be able to be here with you to talk a little bit about our experience. Now, my country, Brazil, as you know, is a bit of a melting pot in terms of ethnic, religious, economic, cultural aspects and everything. And I come from Northeast. I am a pediatric cardiologist. I come from the Northeast, which means that I'm even more exposed to these huge contrasts into, I'm sorry, I hope this is not interfering too much, but they are making some noises, right?
We actually can't hear it, so don't worry about it.
Great. Okay, so I'm very much exposed to these contrasts, and we have serious problems with children. We have large places where they get access to care. We have areas in the countryside where they cannot even get diagnosis and major problems. So from what I've heard from all of you, I think it's a wonderful initiative that we all get together to do this, and that we look into the specific difficulties that each country, each region has. I am a main advocate for telemedicine. I live in a huge country, and one of the major problems is making the people that are in the far-reached, underserved areas have access even to screening, let alone to everything else that comes after that. And as Dr. Ahmed spoke in the beginning, I don't think we should jump for surgical centers, because before doing that, we need people right at the end being able to diagnose, to identify children with heart disease. And this is what we've been doing here in Brazil, in the Northeast, for a while, with what we call the Pediatric Cardiology Network. We try to teach health professional nurses and doctors who are at the very end to at least be able to listen to a child's heart, feel the pulses, and look at the pulse oximetry. And then once they suspect a diagnosis, we train other groups of people to be able to do a screening echo. And then once the screening echo is done and we see that something is abnormal, we train another group to transfer these children to larger hospitals. And we work together trying to organize this whole scenario. We had a big experience not long ago. It lasted for about 7 years with a project in a nearby state that has something like 4 million people spread throughout over 50,000 square miles. It's like the size of Croatia in Paraíba. And by doing that, we were able to screen over 230,000 children for congenital heart disease in a place where really beforehand they were not getting diagnosis. This was a very large project that had also the surgical center being built and all these, and it made a tremendous difference. So I think when I heard Dr. Jenkins saying, yes, it can be done, truly, yes, it can be done. It's a lot of work to be able to push things forward, but yes, and I believe that the more people get together, the more we can get these experiences to be pushed forward. My main concerns, if I could just list them, are first, knowledge. I think we still have very little knowledge about what goes on in low and middle income countries in terms of where these children are, what is needed to get them being diagnosed. So it's very impressive, like the work that's been done in Colombia and in other places, but I think we need more data. Because once we have this data, it's easier even to think about the funding and what is necessary. And then it's easier to obviously reach the governments and other funding agencies. I don't know. I was very impressed also when Shereen said that finance will come, and there's no doubt. And I wish I could be as enthusiastic and hopeful as you are. Well, I live in a country where the government has been, at least over the last few years, very, what should I say, unstable. Perhaps is the word. But anyway, things that are funded at one given moment stop being funded at another given moment and then get funded again, and children continue being born and requiring treatment as throughout this period. So the governmental funding is something that I'm not as enthusiastic about as all of you are. I realize it's necessary, but I find in Brazil, and particularly in the Northeast region, that's something that we need to strengthen, the call and the way that we go about that. So those would be my concerns. Data, so that we would know better how to approach the problem. The use of technologies such as telemedicine, which I think are fundamental for huge geographical areas where we have these big inequalities, and perhaps strengthen our way that we approach governmental issues and all these. We call our network the LEGOS network, and it's an acronym for Lead by Empowering Groups to Optimize Their Solutions, which I think is another thing that's very important. What one group needs is not what another group needs. It's not just moving between different countries, but even within the same country, within different regions, within different areas, we need to have a very open approach to what the needs are and to actually optimize solutions to everyone at their local places. But I'm just very enthusiastic about all these and very happy to be able to be sharing with you some of these ideas and hoping that this is the beginning of a big collaboration and that we can together start turning things for the better for most of these children in different parts of the world. So thank you very much for the invitation. It's great to have the opportunity of being here with you today. Thank you.
Thank you so much, Dr. Mattos, for your very helpful comments, both about your successes and also about continuing challenges, which really highlights the fact that not just the regional and country differerences, but also the role of political situations, which I think we heard about in Ahmad Sir's comments, Farhan Sir's comments about this. I wanted to switch now to the question and answer session from the participants. And I will note that our plan is to keep this going until 8:15, but we completely understand if you have to leave before that. And I wanted to begin with a question that is very close to my heart. So for those of you who don't know, the Global Alliance for Rheumatic and Congenital Hearts was started to be the feet on the ground, really promote the patient family advocacy organizations and the patient family led organizations around the world. And I note that building on something that Dr. Mattos said at the end, she said that we really have to empower the groups. And I believe that there's all kinds of groups. And certainly in our experience, when you talk about financing or something like that, these groups can be very powerful. So that's what Anu Gamanju's comment is about. I will note that currently she is part of a WHO working group on, they're trying to initiate patients living with diseases more into the global health agenda. And she's also works for the government health ministry in Nepal, and she also runs a group for CHD and RHD patients in Nepal. So her question is, what do each of you, this is actually for Dr. Jacobs and Dr. Jenkins specifically, how do you see the role of patient advocacy in this landscape? And I'll also say, any of you can comment as well, but which of you, Dr. Jacobs, Dr. Jenkins, who wants to start with that?
Go ahead, Kathy. I'll let you comment first.
Sure, I can comment. As part of IQIC, I've actually visited quite a few programs around the world, and usually over dinner or over drinks or just in the time between the meetings, I've heard the story of the passionate leaders in the programs who have been successful, and what did it take and what did they do? And many of the leaders believed and have been greatly helped by having a parent or patient advocacy organization, often with doing a combination of both advocacy and philanthropy to just get over some of the initial hurdles that were just way in the way of what they were trying to do. Sometimes that was convincing the government that it had to deploy more doctors to a certain program or hospital. Sometimes it was have more positions, literally. Sometimes it was buying an essential piece of equipment that wasn't there. But without it, you simply could not function. Sometimes it was, helping create some of the other pathways. Sometimes it was funding, just guaranteeing funding for a certain proportion of children so that the program could be sustainable and would have, a way forward. I think what I've heard from the speakers here is there's no one size fits all, right? We're creating these programs within a context. And it's the local people who really will understand that context. And it's that last little piece that can get things going. And that's where I'm really excited about Global Arch and think it's going to be the key that can take a lot of programs over that line.
Thank you so much. Dr. Jacobs.
Right. So first of all, I think everything Kathy said is absolutely spot on correct. And my answer to this question, I'm going to come back to a couple of Kathy's key takeaways, because those key takeaways really relate to this discussion. And, first of all, Kathy said in her talk, the reasons that the dramatic inequity in care exists for congenital heart disease are complex, and went on to say the blueprints to reduce global inequity in care are available, but will require a dedicated effort in each country. And what I've learned, both from collaborating with great advocacy groups like Global Arch, and also from operating on pediatric cardiac surgical missions myself, is that the challenges that need to be overcome vary tremendously from place to place. And the solutions to those challenges are local, even though global resources can be applied to overcome those local problems. In one community, the limit to having the ability to do pediatric heart surgery on straightforward and intermediate complexity lesions ranging from atrial septal defects to tetralogy and AV canal might be limited for the lack of a surgeon. In another community, the problem might be that the surgeon is there, but there's no cardiopulmonary bypass machine, or that the bypass machine is broken and there's no resources to replace it. In another community, the surgeon may be there, the cardiologist may be there, the nurses may be there, the bypass machine may be there, but they don't have an ICU to care for the patients, and they have to share a small facility with the general surgeons, and the same space that's used to recover patients after appendectomies and cholecystectomies also has to be used for postoperative cardiac surgery. Each of these challenges is different and varies from community to community, and therefore each of the solutions to these challenges requires a very unique approach. What we can do on a larger national and international effort through organizations like Global Arch is try to provide resources, both financial and personnel and equipment, to try to overcome the unique challenges that exist within each community. None of it's easy, but all of the hard work ultimately has the tremendous benefit of saving lives. And that's, I think, the reason why it's worth the effort. And I'm very hopeful that a lot of the discussion we have in Washington, D.C., in Global Health and Advocacy Village, at the World Congress, and led by Global Arch, will create a platform that new groups can collaborate with each other to solve some of these unique challenges in these different communities. I hope that answers the question, and I congratulate Kathy and Bistra for some really great talks.
Thank you so much, Dr. Jacobs. And I also just want to note that part of the World Congress, there will be, I believe at last count, there will be over 70 NGOs and patient family advocacy organizations. And I want to note that there will be, we believe, 40 Global Arch member organizations that are patient family led or patient family organizations. And this in part required a really generous contribution from the World Congress organizers, which is free registrations. Because one of the things, as some of you may know, I led the Adult Congenital Heart Association for many years. I am a person living with congenital heart disease, and one of my ongoing frustrations is the number of times that patient and family advocates are invited to things like this, which are very important, but there isn't the financial support. So there has to be free registration. And I know that everybody from an LMIC particularly understands that, but also any family organization, and also travel support, which Global Arch is supporting. So I really appreciate the World Congresses sort of putting their money where their mouth is to make that happen.
Well, thank you. I'd follow up by saying, first of all, what Global Arch is doing at World Congress is of huge importance. And second of all, this whole initiative with the Global Health and Advocacy Village and the advocacy track and the collaboration with Global Arch is really a top priority for the organizers of World Congress. And we invested this money in this charitable initiative because we believe, and I especially believe, that it's the most important part of World Congress. And my hope is that all these groups that Amy just discussed will have the opportunity to collaborate, meet each other, the ones that don't know each other, and this may lead to some unique collaborations and unique solutions to problems that currently exist. And for me, that would be a tremendous victory for World Congress.
Thank you so much.
And let me say one more thing, because I have to go to I've got to leave to go to the operating room now, but I want to thank you guys for organizing this. It was a huge honor to be a part of it. I enjoyed meeting some new friends who gave talks from different countries that were really very relevant to this topic and very powerful. And I'm going to go to do some surgery now. But I look forward to seeing hopefully all of you in Washington, D.C. And thanks for everything that you do.
Thank you so much. Dr. Mattos, I wanted to ask also you to specifically comment on this issue of patient-family organization engagement. I know you have an organization there who are Global Arch members, so do you have any thoughts about that?
Yes, I think it's very, very important. I think it's becoming very clear that the partnership of these organizations are very important together with the hospital groups and other facilities. We do have the Heart Circle, this project that I mentioned to you about, that worked in this in the state of Paraíba with the 4 million people, was run by the organization. It was run by the Heart Circle. And I think it's very important. I think that there are different parts that are very, very necessary to get together if we are to achieve changes. Obviously, each one of us has one particular role to play in this whole situation. We see Dr. Jenkins running to the operating room and being able also to be organizing the meeting on all this. But I think the partnerships where we get the advocates and the families and the patients as well, they're very, very important, because I mean, they see everything that we talk about from a completely different perspective. I've just found out from your speech that you yourself are one person that has lived with congenital heart disease or with these problems. And I think they're very, very important partners if we do want to make changes. And again, when we look at all these differences, the regional differences and the places, people that live in different areas will naturally have different needs and different perspectives. Just as a very minor add to what I said, when we traveled in the countryside in the state of Paraíba, we realized that there were places, and I think Kathy Jenkins was mentioning this a second ago, there were places that were not doing things. And when we went there, all the equipment was there, but what was required was people to know how to use the equipment. So the hospitals were actually installed, or the maternities had an echo machine and had various things. And when we went there, I said, why are we not doing this? Well, no one trained us. And then you go on to another place where you have people that know what to do, but have no equipment. So the needs are very, very different depending on where you are and how you work. And then these empowering groups to optimize their solutions. Where are you on this long road of doing good work in congenital heart disease and detecting children? oh, I have equipment, I don't have personnel, I have personnel, I don't have equipment, I don't have this or those facilities. I think this is putting things together. And then the organizations that have patients and advocates for families are very, very important partners into this group and actually letting us know what the real needs are in a specific scenario. So I think this is very important.
Thank you so much. And then finally, I'm just going to circle back to Dr. Sreehari. Do you want to comment briefly? Unfortunately, we're running out of time, but the role of patient family organizations in Kerala?
Yeah, I too strongly believe that we need to have very strong patient advocacy groups who can guide the government or maybe the private sector who are doing a lot of work. We need people with the correct knowledge and who can guide in developing system, maybe pointing out certain mistakes, or maybe those who can help us in getting some resources. All those things together, if works, the patient advocacy groups definitely is going to improve the quality of the program and maybe extending the program to next level or scaling it up.
Great, thank you so much. Unfortunately, I think we need to end. And what I would note just to end, Global Arch has gotten a lot of call outs on this call, but I do want to just give another circle back to thanking Children's HeartLink. The invisible child, when we were starting out to start Global Arch, a huge piece of this was the creation of the Invisible Child paper, because in order to have advocacy, you need the tools to take to government. And that was truly foundational and was the first essential government white paper that was written on congenital heart disease. It does just deal with specifically children, but we obviously, as I mentioned, have a bigger vision and we're working on that in terms of lifelong care. And also IQIC, which Dr. Jenkins mentioned briefly, but I will note that they've been a huge partner in this world in terms of, if you don't know about them, they're a global consortium to improve quality. And I believe they have over 50, might be much more than that, pediatric cardiac surgical centers participating, which pooling data, which I will note is something we've never achieved in the US. And I really want to give them a huge call out for their role in this landscape. So with that, I would just say thank you so much for attending this webinar. I learned a lot. And just to note that if you had a question and we didn't get to it, or if you think of a question, please email. You can email me at Global Arch. We always want to answer those questions. I want to finally say, please endorse the call to action. You can have everybody endorse it, your mother, your father, as well as your organization, and the link is in the chat bar. So thank you so much. Thank you again for our presenters and panelists, and it's been an honor to lead this webinar. So thank you.
Thank you.
Thank you.